So I'm excited today for our lecture. Joining me today is Dr. Tracy Vernon-Platt to discuss EKG interpretation for oncology APPs, and she has ran from clinic to be able to share her expertise. So Dr. Vernon-Platt earned both her bachelor's and master's degrees from the University of North Carolina at Chapel Hill in 1996 and 2005, respectively. She did earn her doctorate in nursing practice from Duke University in 2020. She has been an adult nurse practitioner with the cardiac surgery team at UNC Health since 2005 and maintains an active clinical practice with that team. And Dr. Vernon-Platt also started teaching in the UNC graduate nursing program and currently serves as the program director for the Adult Gerontology Primary Care Nurse Practitioner Program. And she is a member of the American Nurses Association, the American Association of Nurse Practitioners, as well as the American College of Cardiology. So thank you for joining me this afternoon. So outside of your professional bio, anything personal or a hobby you'd like to share with our audience?
So probably it's not even so much of a hobby as right now I spend a lot of my time chasing after my teenagers and all the sports that they do. They're both very active and stuff, and so that really kind of keeps me busy these days, but it's fun.
And that's your hobby. Kids. So here is a sample of what the Poll Everywhere questions will look like. Reminder, pollev.com and enter UNC LCN to participate. Here are our disclosures. And then on our next slide, you can practice and get set up for your Poll Everywhere. Here's our first practice question. An electrocardiogram, or EKG, is a quick, painless, and non-invasive test that measures the electrical activity of the heart. True or false? And anyone like to take a stab at this? Okay, so I will say true, even though I'm not on Poll EV. But let us get started, and I will pass it on to Dr. Vernon-Platt.
Thank you so much for inviting me to present today. This is something that I do enjoy presenting on, and I do find that whether you're an APP or some other part of the healthcare profession, people really struggle with EKG interpretation. And so we will go through a stepwise approach today on how to interpret EKGs, and then towards the end, we'll really kind of relate it back to oncology practice. So here are the objectives. Now, keep in mind, in order to become proficient and competent at EKG interpretation, you need to practice. This is something that, you can listen to this webinar, and if you put it aside for the next 6 months, you're going to probably forget everything I told you. So I really encourage you to practice. And so what does that mean? It means every time you have a patient who you're getting an EKG or they have an EKG in their chart, look at it and do your own interpretation. That's kind of my recommendation for step one. Step two is look, if you just did the EKG machine will give you an interpretation. It may or may not be accurate, but it will give you information. So that's kind of step two. And then step three is once it is formally read by cardiology, look at their interpretation and then compare that to how you interpreted the EKG. If you do this with each EKG you encounter for a patient, you will become very skilled at EKG interpretation. Here is a general outline of what we're going to cover. We're going to go through kind of each of these steps, and I really hope that you come away with a systematic way to look at an EKG and make your own interpretation and feel confident in what you are determining about that patient at that moment in time. Because remember, an EKG is a snapshot in time, but it does give us information, more detailed information about that patient's cardiac physiology or pathology. So the cardiac cycle is one full heartbeat. And you see that as an EKG tracing on the EKG paper. It's a start of one QRS complex or one, cardiac cycle to the start of the next. And this can give you a lot of information about the patient's heart, their heart function or dysfunction. And keep in mind, a lot of the drugs that are prescribed to manage cancer disorders, so various cancer therapies, do increase risk of cardiac abnormalities. So some of them are considered cardiotoxic drugs, so they can actually cause heart dysfunction, heart failure, and then some will predispose that patient to developing atrial fibrillation or other arrhythmias. And we'll really highlight that as we get towards the end of the presentation today. So here is what the normal conduction system of the heart looks like. And I'm going to try to use the writing device. So the normal pacemaker of the heart is the SA node, and that's up here on this slide. When the heart functions in the normal way, the SA node generates electrical impulses that travel from the SA node down to the AV node. Then it starts going down to the level of the ventricle. It travels down this network, these Purkinje fibers, the left and right bundle branches, and then out to the left ventricle and then the right ventricle. So that is the normal progression of the conduction system in the heart. And the electrical activity is generated by those pacemaker cells and then transmitted across cells in the heart. As that impulse travels, it causes those myocytes to contract, and then that results in contraction of the heart muscle. So I think it's helpful to think about what's actually going on at that physiologic level in the heart when you think about EKG interpretation. So first we get the depolarization through the heart that's going to cause contraction. You see a tracing of this electrical activity on the EKG paper, and that tracing on the EKG paper gives us information about structure and function of the heart itself. And we'll talk about normal findings and abnormal findings. A key takeaway from today should be that you need to know your normals. If you don't know what a normal EKG should look like, it's going to be hard to differentiate an abnormal EKG. And we'll kind of revisit that throughout today, or throughout this hour. So when we think about that intrinsic pacemaker in the heart, the SA node, that's that little spot up here in the right atrium, it generates the normal kind of electrical activity, and a normal heart rate is considered to be 60 to 100. Now that's quite a variable range, right? 60 is on the slower side, 100 is on the faster side. Really probably 70s and 80s is what we consider very normal heart rates. But if the SA node is generating those electrical impulses and the rest of the heart is responding, the heart rate will probably be between 60 and 100. Then if we move to an atrial foci, meaning somewhere up here in the atrial tissue is generating the electrical impulse because that dominant pacemaker, this SA node, stops doing its job, we usually see a little bit lower range of heart rates, maybe around 60 or 80. If the SA node and the atrial foci don't kick in, then the AV node becomes the default pacemaker, and we see even slower heart rates, usually in the range of 40 to 60. If all of those kind of atrial and then AV node fail to generate impulses, or those impulses are not transmitted to the level of the ventricle because of some type of pathologic condition, then the ventricles take over and they will pace around 20 to 40 beats per minute, which is very low. That's a very bradycardic heart rate. And so sometimes by looking at that heart rate, especially if the patient's not on a bunch of medications impacting the heart rate, you might be able to tell kind of where in that area of the heart the electrical signals are coming from. All right, so this is a schematic that shows you the normal waveforms we see on an EKG tracing, and we'll talk about what each of those means. So we start with a P wave, which is atrial depolarization. We move on to a QRS complex, which is ventricular depolarization, and then forward to the end of the T wave, which is where that ventricle is repolarizing. Now, you don't see atrial repolarization on the EKG because it's a much smaller electrical signal and it's hidden within the QRS complex. So you're not going to see that on the EKG. We also will note that there are time intervals of how long that P wave should be, how long the QRS complex should be, and all the way out to that T wave. So we have normal ranges for each of these. Again, know your normals. And then when they're abnormal, that again gives us that information about the pathology in the heart. You will see these small squares on the EKG paper, and going horizontally, it is time. So one box is 0.02 seconds. Two boxes. When we get to, 0.04 seconds. My math is escaping me. One large box, which is 5 small boxes, is 0.2. So that's measured in milliseconds. When we look at the up and down, the vertical aspect of the EKG, it's voltage, and it's measured in millimeters. So one small box is 1 millimeter. A large box has 5 millimeters. And that becomes important as we measure both the intervals of the PR interval, the QRS complex, our QT interval, and the amplitude, right? The height of things like our QRS complexes. All of that comes into play when we're interpreting the EKG. So here you see, again, the intervals and what's considered normal. Know your normals. So the PR interval is that range of the start of the P wave to the start of the QRS complex. Normal is 0.12 to 0.2. Narrow PR intervals are usually not something we pay much attention to, but when the PR interval goes beyond 0.2, then that's considered a first-degree heart block. And that can be normal for some people, but can also indicate underlying pathology. Then the QRS complex should be upright for the most part and narrow. So around 0.1 milliseconds is pretty typical, sometimes 0.08, but really above 0.12 is considered that widened QRS complex. And that, again, that QRS complex shows us that ventricular systole of contraction of the ventricle, and then we move on to that T wave. And so that ST segment, this is the segment between the QRS complex and the start of the T wave. That should be level with the baseline. So it means it shouldn't be elevated above the baseline. It shouldn't be depressed below it. And then the T wave is that final repolarization phase of the ventricle. The QT interval is something that's very important, especially when you think about your patients with cancer who are on medications that prolong the QT interval. And we'll look at more examples of this. But from the start of the QRS complex to the end of the T wave is that QT interval. You can see the normal range there is about 320 to 400 milliseconds. When it gets over 500 milliseconds, we consider that pathologic. So that's something we need to pay attention to. And medications are one of the most common things that prolong the QT interval. And this is showing you the relationship of the P wave, the QRS complex, and the T wave to what is going on at the level of the heart. So you can see the P wave represents our atria, and the depolarization and contraction. The QRS complex is looking at that contraction of the ventricles. And then that T wave is when we're going through that repolarization phase. Now, we place EKG leads on our patients, and that allows us to capture a snapshot of the electrical signals. We have limb leads, so if any of you have ever placed EKG leads, and I'm sure many of you have done that, you know, there's a certain configuration where you place them on the extremities, and then you're going to also place some across the chest wall. So this is the limb leads, so leads 1, 2, 3, AVF, AVL, and AVR, and you can just see the direction of the vector that EKG machine is looking, right? It's looking from the right hand to the left hand down to the foot, and by doing that, that helps determine what that EKG tracing will then look like on the EKG paper. And then here we look at the chest leads, the ventricular leads. You know, so again, think about proper placement of EKG leads. V1 starts here on the right side of the sternum around the fourth intercostal space, lead 2, and then it will wrap around, and V6 ends up down here close to the axillary area. And when you look at the way these leads are, they really wrap around the heart itself. And so it's giving us a different view of the heart. And so those EKG tracings will look differently than ones generated from the limb leads. So think of the placement of the EKG leads and then what we see on the EKG paper as a snapshot. It's like a camera is moving around the patient's body and capturing different images, but it's all coming from obviously the same heart, the same person. So this is an example of a normal EKG tracing. Again, know your normals. You're going to hear me say that a lot today. But we notice, look at lead 1, look at lead 2, look at lead 3. Those QRS complexes are all narrow and upright. So that's what we expect to see in those leads. When we get to the V leads, we see lead V1 starts negative, V2 is negative, V3 is what we call equiphasic, so it's kind of partial negative and partial positive. And then as we get to V4, V5 and V6, we now have upright QRS complexes. That's called R-wave progression, and that is a normal thing to find on an EKG, that we move from our negatively deflected leads in V1 to positive deflections by V4, 5, and 6. And again, that is what we expect to see on a normal EKG tracing. You also want to pay attention to things like your P waves. In general, your P wave should be the same direction as your QRS complex. Same thing with your T waves. And we expect to see a P wave before each QRS complex. And up here, you see we have all of our 12 leads. At the bottom, you're going to have a tracing. And usually this is a longer, about a 30-second tracing of one lead. Sometimes you'll have a couple leads at the bottom. That really allows you to do a more thorough interpretation, because in the upper, on the full 12 lead, you only get a couple beats, a couple QRS cycles. But in that tracing, you're going to see sometimes 30 seconds of EKG tracings. And so we can use that to do a more thorough interpretation. This is a cartoon drawing that shows you, again, what we expect to see in each of the leads. Again, notice the P wave, the QRS, the upright T wave. But then look at lead AVR, where everything is negatively deflected. So that's considered normal in that lead. And then we have things like the QRS complex. And when you're thinking of the QRS complex, not every EKG tracing has a Q, an R, and an S wave, but we refer to it as the QRS complex. So the Q wave is always the first negative deflection of the QRS complex. And here's an example in V6 or V5 and V6 of a very small negatively deflected Q wave. But if we look at our other leads, we don't always see a Q wave to start it. And that's, again, that's normal. The first upright is the R wave, and then that second negative is the S wave. So it's all called the QRS complex. Now, when we have wide and deep Q waves, those are pathologic, and those can be indicative of a prior myocardial infarction. All right, so here is an example of an EKG tracing, or an EKG of a patient. And give you an example of what type of abnormalities, once you become proficient at this, that you might be able to pick up on. So in this particular EKG tracing, it looks very regular to me. I see small Q waves before my QRS complexes. I see T waves, but I notice that my T waves are really tall. They look like little tents. And that is referred to as peaked T waves. That is definitely an abnormality on an EKG. And when you look back to this one, you note those T waves are not tall and peaked like that. So again, that's an abnormality that you can pick up on. Well, I can tell you in this particular patient, this patient had a high potassium level, and those peaked T waves appeared after he underwent surgery and had a high potassium level. And so that was a finding that was picked up, and then obviously that can then be addressed. And so this is just an example of how you can use the EKG to give you more information about what's going on with your patient. And here's that same patient later in the day. actually, this was after they'd gone home after surgery, and their EKG had normalized, and they no longer had the peaked T waves. So again, one key thing with EKG interpretation is when you have prior ones to compare it to, that can be very, very helpful as you navigate through the interpretations. It's always helpful to compare it to a prior EKG. In this case, it improved, but sometimes you'll get an EKG that's very abnormal, and you'll want to be able to refer to an earlier EKG. So know your normals and always refer to prior EKGs when you are able to. Obviously, you're not always going to have a prior EKG for a patient. All right, so one of the things we're going to do with an EKG is we have to calculate the heart rate. Now, I'm sure you're thinking, oh, the EKG machine does it for me. I don't need to do this. I really encourage you to learn how to calculate a heart rate, because there are many times I have looked at EKGs and the machine gave me an incorrect heart rate. Some examples of that can be if a patient has a pacemaker, and when the EKG was done, nobody told the pacemaker machine that the patient had a pacemaker. It'll sometimes count pacer spikes as a QRS complex and then double the heart rate. I've seen in patients with heart block that it counted the heart rate very incorrectly. So I'm going to show you two very quick methods to interpret your heart rate. One is you start with a QRS complex on a solid line, and these are kind of predetermined intervals for heart rate. So we start on a solid line, 300, 150, 100, 75, 60. So that means this heart rate is between 60 and 75. It's probably, in the high 60s. So that is a very quick way to do it. This only is accurate, though, if your patient's heart rate is regular. If you have a really irregular heart rate, then this is really not going to be as helpful. The other way we can interpret our EKG is to actually count out the number of QRS complexes and then multiply. So if you count out, and what we do is we have to count out the large boxes. So if you count out 15 large boxes and count how many EKG tracings are within that, you're going to multiply by 20, and that's going to give you your EKG heart rate. This is one of those things you have to practice, but again, I really encourage you to try and do this yourself. So looking at this EKG, you can see I've made some markings on here. And so I've counted out a 30-second strip for you for the EKG. And so you could calculate the heart rate that way by saying 1, 2, 3, 4, 5, 6, 7 QRS complexes. I'm going to multiply that by 10 because it's a 30-second strip, and the heart rate should be around 70 or somewhere in the 70s. So again, this is one way to help you. Oh, sorry, that was supposed to be a poll EV question. I'm sorry. I just ruined the poll EV question. But I was going to ask you each to go ahead and calculate the EKG heart rate yourself, but definitely something that you're going to want to do.
And just a reminder, if there's any clarifications that you'd like for Dr. Vernon-Platt, please put it in the chat. I'm keeping an eye on that, and we can pause to clarify anything that she's going over.
All right, so we'll keep moving along. And so here hold on, I feel like I'm going backwards. There we go. Okay, so here is another example of, this is an EKG where the EKG machine actually told me this patient's heart rate was 68, that was the ventricular rate was around 68 or 70. However, if you notice, this heart rate is very slow. These are my ventricular beats. And this patient's ventricular rate was actually in the 40s. But for some reason, it calculated their heart rate as being in around 68 or 70. And so this is a patient where I calculated it myself. They were in a 2-to-1 heart block, and that's obviously very concerning. And so, again, doing the interpretation yourself can be very helpful. All right, let's talk about some rhythm concepts. So when we talk about bradycardia versus tachycardia, these are just definitions. Bradycardia is a heart rate less than 60. Tachycardia is a heart rate over 60. So you want to determine that. Does your patient have bradycardia or tachycardia based on the EKG? And is it regular or irregular? When you look at those QRS complexes, do you see set intervals for each of your QRS complexes? Are they occurring right after each other in a consistent pattern, or are they irregular? And then, are your QRS complexes wide or narrow? Narrow is normal. You also want to see if you have a P wave prior to each QRS complex. because that would be considered the normal finding on an EKG. So on this EKG, this looks like it's fast. If we do a quick heart rate assessment and we start here, we're going to go 300, 150, 100. So this heart rate's probably about 110. So it is tachycardic because it's over 110. I see P waves before each QRS complex, and that's very consistent throughout. So this looks to me to be a regular EKG, but it's sinus tachycardia. All right, and then axis is the direction of the vectors, the direction of depolarization as it moves through the heart. And this is captured on within some of the EKG leads. A normal depolarization is down and to the left because our heart actually sits a little bit into the left side of our chest, and that left ventricle has the most mass on the heart. And so a normal axis is when we have an upright lead 1 and an upright AVF. That's a normal axis. When it's deviated, we can have deviations for different reasons. So if lead 1 is positive and lead AVF is negative, that is a left axis deviation. If lead 1 is negative but lead AVF is positive, that's a right axis deviation. And so what does that mean? Well, here's examples of why somebody might have a right axis deviation or a left axis deviation. Typically, left axis deviations are more common, so left ventricular hypertrophy causes that. And that makes sense if we have a thickened left ventricle, often for something like uncontrolled hypertension, then we're going to have that stronger pull to that left ventricular area, and we're going to get a deviation in that EKG tracing. Right axis deviations, many reasons why we see them. They can be normal in children. I've actually seen them in a number of my patients who had large atrial septal defects or ASDs, and they had right axis deviations because of that. And these were adults who had large ASDs that had not been repaired before adulthood, and so they had significant right axis deviations. So just kind of giving you that kind of information. So when you do find it on an EKG, you can think about, well, why is there this finding? And then left ventricular hypertrophy. So this is when our left ventricle has increased muscle mass. And I always like to say with the heart, bigger is not better. We want small, compact hearts that work efficiently. When we get left ventricular hypertrophy, that muscle gets really thickened, and we don't have adequate blood flow always to the heart muscle to support that thickened muscle. So how is this reflected on an EKG? Well, what we see is our QRS complexes, and we look in V4 and 5, this upright QRS complex gets very tall, right? It's almost running into the one above it. And then in lead V2 or V1, we get a very deep S wave. And we measure that. It's a measurement. So if I measure here, remember we do it in millimeters. So 5, 10, 15, 20, about 25, 30, 35, 40. Actually might be about 42. So when I measure all of that amplitude, I get over 35 millimeters, which meets criteria for left ventricular hypertrophy. And so you will see that on your EKG. And this is just kind of giving you the definitions of where to look and what measurements qualify for left ventricular hypertrophy. And then we have the QT interval. So this is the start of that QRS complex to the end of the T wave. And this measurement is dependent on heart rate. And so when we think about, should we be concerned about a patient's QT interval, we use the QTC, or the corrected QT interval, because it takes into consideration the heart rate. There are ways you can calculate these by hand. There's also a lot of online calculators, so I encourage you just to use those. It's not something you have to figure out how to do. Just use an online calculator. But the key is, if it's over 500 milliseconds, that is concerning, and we need to pay attention to that. In particular, if you have a patient who has a prolonged QT interval and you're going to prescribe something that we know could prolong the QT interval, you need to really pay attention, and that's a time to get another EKG before prescribing, and then a few months after prescribing, or a month after prescribing, to determine if the addition of that medication prolonged the patient's QT interval. So medications are probably the most common thing we see that will prolong the QT interval. Electrolyte abnormalities can do this as well, though typically it's going to be really abnormal electrolytes. Like a potassium of 5.1 is probably not going to prolong your QT, or a potassium of 3.4. It's usually ones that are quite abnormal, like a potassium in the 2s. Or low potassium and low magnesium. But we need to pay attention to that, because when that QT interval prolongs, we can get ventricular arrhythmias like torsades, and that, as we know, can be life-threatening. And so when you look at these medications, look at something like antiemetics, right? That is commonly prescribed to patients who have cancer or going through cancer treatments. And if the cancer treatment itself could prolong the QT and the antiemetic could prolong the QT, we need to pay attention to this and make sure we're looking at the EKG both before and then after prescribing. Certainly antiarrhythmic medications, right? We prescribe these so that we can alter those abnormal heart rhythms. If someone has atrial fibrillation, we're often prescribing antiarrhythmics, but these medications are known to prolong the QT, and these medications are additive. So if you prescribe one and then another, you need to make sure you're assessing the patient appropriately. I had actually a patient in clinic this week who had postoperative atrial fibrillation. He was started on amiodarone, and when he came back to clinic, we always get a 12-lead EKG, and his QTC was about 524. When he was in the hospital, it was normal. So I discontinued his amiodarone because that was prolonging his QT and had been a significant change, and he wasn't in atrial fibrillation anymore. So I felt comfortable discontinuing it, but you have to pay attention to these things. And here's showing you an example on this tracing. If we start at the QRS complex and we move to the end of that T wave, and we remember this is time in milliseconds, and we calculate that this QT interval would be about 0.6 seconds, and then the QTC is 0.625. So remember, over 500 is considered pathologic, and a change of 60 milliseconds is something you should pay attention to too. So if their QT interval was, say, 490 and now it's 510, if it's been that way for a long time, I probably wouldn't be as concerned as if it was 440 and now it's 540, and especially if I prescribed something that I know prolongs the QT. So hopefully that's starting to make sense. So again, as you can, spend time interpreting EKGs. And this one is another example of that prolonged QT. So again, start at your QRS complex, go all the way to the end of that T wave. And in this patient, their QTC was about 646, so definitely a prolonged QT. Okay, so what is the most common arrhythmia? This is one of the poll EV questions, and I did not ruin it this time. Does anybody want to answer this?
So I have it over here. So we have a mix of results coming in. Atrial fibrillation and premature ventricular contractions, but majority are answering atrial fibrillation. Oh, we have sinus tach coming in also.
Okay, all right. So, not surprised that these are kind of diverse answers. So one key thing is an arrhythmia is any kind of abnormal heartbeat. It's a really general term. It's a generic term, and it really doesn't tell us much of anything. So the most common arrhythmia is actually sinus tachycardia, because that is a heart rate that we define as being too fast, a heart rate over 100. So if I put what is the most common pathologic arrhythmia, that would definitely be atrial fibrillation. But, you know, sinus tachycardia can be physiologic. If you go for a run or for a fast walk or you get anxious, you might have some sinus tachycardia. But you shouldn't get atrial fibrillation, right, if you go for a run or go for a walk or get anxious. And then certainly when we have premature ventricular contractions, things resulting from the ventricle should always be concerning because it often is indicative of underlying pathology. And then sinus bradycardia means a slow heart rate. Again, that can be normal. If you have a conditioned athlete, I've had patients whose heart rates were in the 40s and they were fine. That was their normal heart rate. I've also had patients with heart rates in their 30s and 40s who were in third-degree heart block. So again, we get that EKG to figure out why that heart rate's so slow. But sinus bradycardia itself is typically not that concerning. So here's some examples of different arrhythmias, and we're going to kind of move through these, especially focusing on atrial fibrillation. All right, what's the most common cause of pathologic arrhythmias?
So answers starting to come in. We have electrolyte abnormalities, comorbid conditions, and now increasing age. It's kind of all even.
Okay.
Comorbid conditions is
Okay.
now winning as the...
Well, and it is comorbid conditions. So, for those of us who worked in the hospital, especially inpatient, we pay a lot of attention to electrolyte abnormalities, but those really become problematic often because of the underlying comorbid conditions. So the more, heart hypertension, coronary artery disease, COPD. So patients who have multiple of these comorbid conditions have an increased risk of developing some type of pathologic arrhythmia. But electrolytes contribute, and we know as people get older, they have more comorbid conditions. So that certainly contributes, and congenital heart defects does contribute, but those are much less frequent than these other things. All right, so the clinical significance of arrhythmias, just because someone has an arrhythmia doesn't mean, we have to get worried or concerned. It depends on the patient and how they are responding, right? So if someone has atrial fibrillation, we need to figure out why. We need to do appropriate treatments. But even new atrial fibrillation can often be managed as an outpatient and worked up that way, and patients don't need to be sent to the emergency room, especially if their ventricular response is less than 100 or less than 120. If their heart rate's stable, if they're feeling okay. So you really have to think about what is the duration of the rhythm, right? So if someone has ventricular tachycardia, and it's prolonged, that duration is concerning, and that patient will probably not be okay. But think about ventricular response. If someone has atrial fibrillation, but their ventricles responding with 70 beats a minute, we can manage that probably just fine in an outpatient setting. But if their ventricles responding 150 times a minute, then we need to do something more aggressively to treat them. The underlying cardiac function certainly comes into play. The more abnormal cardiac function they have, the harder it's going to be for them to manage those arrhythmias, and then certainly comorbid conditions. So when we have an arrhythmia, you want to recognize it and diagnose it. You want to assess for any kind of hemodynamic changes. What are the patient's underlying conditions? And then determine, do we need to control the heart rate? Do we need to control the heart rhythm? Do we need to cardiovert? Certainly, if you're going to cardiovert, you're sending that patient probably off to the emergency room if you're seeing him in clinic. And so those extremes of heart rate, less than 40, over 150, more concerning. Multiple comorbidities, and on top of that, electrolyte abnormalities. These are all things that we're going to need to treat more aggressively. So atrial arrhythmias are very common, and these can range from premature atrial contractions to atrial fibrillation, all the way to things like atrial tachycardias and supraventricular tachycardias. So here's an example of PACs. PACs are just early atrial beats, so premature atrial contraction. Most times these are benign. And so, you look here, we have 3 normal beats. Here we can see that early beat. Right? So it's just happening earlier than we think it should. It's coming from a different area of the atria than the primary pacemaker. But for many people, these can be normal, and we don't necessarily need to do anything to treat them. And here I've just circled on a patient's EKG, those atrial contractions, those PACs. And then when we look at this rhythm, though, what do we see? So in this rhythm, or this EKG, we see that it's irregular. So while we have narrow QRS complexes, I really don't see P waves before my QRS complexes. And these QRS complexes are happening at an irregular pattern. So it's irregular. I don't have definitive P waves. So this would be an example of atrial fibrillation. Again, this is the most common pathologic arrhythmia. And certainly in your patients who have comorbid conditions and are getting cancer treatments, you probably see this fairly frequently. Here's another example of atrial fibrillation. So again, it's not that fast. The heart rate is about 80 or so, but we have an irregular pattern of our QRS complexes. And when we look for P waves and we go beat to beat to beat, I'm not seeing discernible P waves. You always want to make sure you confirm in 2 leads, though, that there's no P waves, because sometimes they're just hard to see. But in this one, I look at 2 leads, it's irregular, I don't have discernible P waves, so this is an example of atrial fibrillation. So here's just characteristics of atrial fibrillation. It's irregular. We call them F waves, lowercase f waves, because there are no P waves. Your P to QRS ratio is absent because you don't have P waves. And your QRS complex could be normal or wide. If it's wide, there's probably some other underlying things going on with that heart, not just atrial fibrillation. So atrial fibrillation in cancer is fairly common. 1 to 2% of our population develops AFib, but up to 30% of people with cancer may develop atrial fibrillation. And remember, our patients with cancer are not always, but often older. We know the older someone is, the longer they live, the more likely they are to develop a cancerous process. We also see atrial fibrillation commonly after surgeries. So if your patient, say, has a lung resection for lung cancer, they're going to be at an increased risk of atrial fibrillation. And then the drugs we prescribe to treat cancers do contribute to that atrial fibrillation. So showing you kind of broadly, why do we see AFib in patients with cancer? And there's lots of different things that contribute to that, but there's traditional risk factors. So patients who have hypertension, diabetes, all those things, we know are more likely to develop atrial fibrillation. And then you add cancer treatments on top of that, whether it's a surgery, radiotherapy, chemotherapy, targeted therapies, all of that can also increase risk of atrial fibrillation. Some of the cancer-related comorbidities. So are we causing anemia or metabolic disorders? Are those drugs that we're prescribing contributing to that? There's an imbalance of the autonomic nervous system. There's some chronic inflammation. So you can see all of those things are really additive and why our patients with cancer have such a high risk of atrial fibrillation. And this is just showing you some examples of drugs that can increase risk for atrial fibrillation. So what do we do with these patients? I know for some people you want to know, okay, great, I know they have AFib. How do I manage them? Well, number one, what is the heart rate? You want it controlled. So typically less than 120, ideally less than 100, but we can prescribe nodal blocking agents, our beta blockers, to slow that heart rate down. Rhythm control is where we prescribe true antiarrhythmics. So Tecousin, flecainide, amiodarone, sotalol, things that will actually convert that patient. You probably won't prescribe that in your practice. You will prescribe the beta blockers, but then our cardiology colleague can certainly help us with that rhythm control piece. We need to assess if they need anticoagulated, and many of these patients will meet criteria for anticoagulation. You want to treat their risk factors, and then we have an AFib clinic that we can send our patients to. They are fantastic about getting patients in, and there's probably other systems across the state that have a similar thing. But certainly a good resource. So when you're determining need for anticoagulation, you want to calculate your CHADS-VASc score as well as HAS-BLED. So CHADS-VASc is what is the risk of developing a clot related to atrial fibrillation. Those patients who have a CHADS-VASc, usually of 1 or 2 and above, definitely 2 and above, meet criteria for anticoagulation. HAS-BLED is what is the risk of bleeding if we're going to put them on anticoagulation. And so you calculate both of these and make your decision about whether or not to prescribe anticoagulation.
I'm going to interrupt for a question. Can AFib be seen in 5-lead EKG?
Yes, absolutely. Really, you need 2 leads. That's a great question. You really need 2 leads to be able to diagnose atrial fibrillation. And you know, people use their smartphones now. Now, I don't know that I would make a definitive diagnosis with a patient just based on their smartphone alone, but they're pretty good. They really are. But a 5-lead EKG should be able to tell you, yes, this is definitively atrial fibrillation. Thank you for your question. Here is just information about the UNC AFib clinic. Again, they usually can get patients in within a few days. Again, everybody with AFib does not need to go to the emergency room. And there's a lot of data supporting that in the literature, that these patients can be safely diagnosed and treated if they're stable. This is just showing you the pillars of AFib management. This is from the Journal of the American College of Cardiology. It's a great resource, but thinking about, you know, stroke risk, looking at risk factors, and then managing that heart rate either through rate control or rhythm control. So here's another rhythm. This one is regular. Pretty regular, and we see what looks like P waves. However, we see a whole lot of them. So this is atrial flutter, and in this situation, we typically will have pretty regular R to R intervals, but then we have a whole lot of what looks like P waves, but these are actually flutter waves. And so in this patient, they have 1, 2, 3, 4, actually it looks like 5 flutter waves to this QRS complex, and here they have about 3. So you can have a variable flutter, but that's atrial flutter. We treat it somewhat similar to atrial fibrillation. We're not going to go into details on that now, but recognize it, and again, think about how we can treat this. Here's another example of a 12 lead with flutter, and if you look down here at lead V5, You look at this and think the patient has atrial fibrillation, right? We don't see P waves. It's irregular. But if we come up here in V1 and lead 2, we see those flutter waves. So that's why we always look at least 2 leads, and it's better if you have, 3 or so to really determine what is going on with the patient. So this is another example of atrial flutter. And again, just showing you kind of definitions. So our atrial rate is usually very fast. Ventricular rate and flutter might not be very tachycardic, but can get very fast. We call these capital F waves for flutter waves. And again, your QRS could be normal or wide. All right, and so looking at this rhythm, this is an example of another type of atrial arrhythmia. And if you look at this one, it's pretty regular, right? When we look at our QRS complexes, they actually map out pretty regularly. But look at our P waves. Notice all of our P waves are negatively deflected, right? Our P waves, for the most part, in all your leads should be positive. So this is an example of an atrial tachycardia where we're seeing a kind of retrograde P wave. And again, these are things that sometimes this is hard to pick up on when you haven't looked at a lot of EKG tracings, but know your normals and know that our P waves should be upright. In this case, they're negative, and so this is an atrial tachycardia. And here's an example of a supraventricular tachycardia. So this is where we have a patient who has these normal QRS complexes, and then they go into this burst of tachycardia. It looks very regular, and do you have P waves? It's impossible to tell. It is too fast, and you would actually have to slow it down to be able to determine if there are P waves there or not. But this is an example of an SVT, and here's a 12-lead EKG where a patient has an SVT. All right, so EKG findings in patients with cancer treatment. So again, atrial fibrillation is going to be fairly common, something you should look for, especially if your patient's complaining of some arrhythmias, feeling like their heart's beating irregularly, or sometimes they'll say, I'm having palpitations or my heart's beating out of my chest. So that's a time you want to get an EKG. QT prolongation. This predisposes people to ventricular arrhythmias. So it's helpful to know the baseline EKG of your patient, and then if you are prescribing drugs or they're already on drugs that prolong the QT, make sure we're following up. We sometimes see bradyarrhythmias, so those slower arrhythmias in people with cancer, but those are going to be less common. AFib and then QT prolongation are going to be the more common ones that you're going to see. And so risk factors for prolonged QT, well, certainly electrolyte abnormalities. And when you think about it, a lot of the drugs we prescribe, especially if we're doing things like diuretics to help with that volume overload someone may get from cancer treatments, or steroids, which can affect, fluid balance and electrolytes, those can predispose that patient to prolonged QT because we're causing electrolyte abnormalities. Thyroid dysfunction is another one, and that's something we can check very easily. Drug-drug interactions. So the more drugs a patient's on that prolongs the QT, the more likely they are to have that QT prolongation. And then think about our kidney function and our liver function in our patients. So if your patient has chronic kidney disease, we're going to have decreased clearance of drugs from the body. Same thing if they have hepatic dysfunction. Drugs are not going to be metabolized as efficiently. Those drug levels are going to stay higher longer, and that could predispose a patient to QT prolongation when they're on drugs that prolong the QT. So again, thinking about risk factors specific to patients with cancer. So we have those non-chemotherapeutic risk factors, so traditional risk factors we think of, but also, did they have an underlying arrhythmia to start with? Did they have that before they ever had cancer or went through cancer treatments? Do they have underlying coronary disease? Do they have an underlying congenital heart condition? And then think about the cardiotoxicity of chemotherapies. That will certainly contribute. And what about direct cardiac involvement of the cancer itself? Probably less common for cancers to cause, cardiac invasiveness, but we see it. And so that certainly could predispose that patient to more arrhythmias. And then electrolyte abnormalities. We keep kind of revisiting that. This is just an algorithm to show you maybe how to navigate through. Okay, so I have a patient, we're starting them on drug therapy. this is a high risk. So how do we navigate through this? So I think it's always helpful to have an algorithm that you can navigate through to kind of walk through the steps of what should I do. But I think a good guideline is to think about baseline EKGs. If you don't have one on the patient, you know you're going to be prescribing things that could impact cardiac arrhythmias, prolonged QT. You know, an EKG, as we said at the beginning, it's fast, it's simple, it's inexpensive. And so having that baseline information is going to be really important. Here's just some examples of drugs that you may see someone with cancer take and the impact on QT prolongation. So antibiotics are a big one. Our macrolide antibiotics, they have a moderate risk of prolonging the QT. Antifungals, so if your patient has cancer treatments, they develop a fungal infection and need antifungals, and they're already on chemotherapy or some other drug that prolongs the QT, we should be paying attention to that. The fluoroquinolones, and you can see there on that list, antiemetics, all of those we need to pay attention to, and just make sure we are kind of doing our due diligence of looking at the EKG, deciding when to follow up on that EKG tracing as well, and getting another EKG. This is a website I found. It's called Credible Meds. This is something you have access to register for, and you can actually look at the risk categories of the different drugs, and it's free registration. So this might be a resource for you as you're prescribing medications or determining who is higher risk for arrhythmias and QT prolongation. And then this EKG shows you an example of torsades. So this is what can happen if a patient has a prolonged QT. Remember, it's impacting that repolarization phase, and so the patient can develop torsades, which can be life-threatening. In this EKG, this was a patient who was a 56-year-old who had hypokalemia with a potassium of about 2.4 and hypomagnesia with a magnesium of about 1.6. So that's where those electrolyte abnormalities contributed to the development of QT prolongation and torsades. And then how do we manage QT prolongation? Well, you're going to certainly check your electrolytes. They might be normal, but you're always going to check that. You want to think about the medication therapy. Think about the medical therapy. Are there diuretics we could discontinue? Are there steroids we could discontinue? And you may not be able to do that. It might be that this is really important for the treatment of their cancer, and therefore we need to continue these drugs. In that case, you probably want to involve cardiology and get some more input on how to best manage this. But if you can decrease or discontinue drugs that prolong the QT, you'll want to do that, and monitor with EKGs. And keeping in mind that that change of 60 milliseconds in the QTC is something to pay attention to. So if it increases by 60 milliseconds or more, it's over 500, we need to pay attention to that. And then this is a cardiac risk calculator I actually found when I was doing some research for this webinar. And this is where you can look at cardiac risk. And so it's called the EKG score and can help you determine the risk of cardiovascular toxicities and looking at that QT in patients on anti-cancer therapies. So again, just another resource to have as you're managing your patients. And then here are some websites. So Life in the Fast Lane, there's a YouTube series called Bravo that is many hours of EKG interpretation, but it's great. It's about 12 hours. I have watched all of it, but really, really informative. And then certainly you can, use some textbook resources. And then certainly these are the different references that were used to put this webinar together. So I think that concludes.
Thank you so much. I learned a ton, so thank you for sharing your expertise. You may submit questions through Poll Everywhere now. We have a few minutes to spend together if you have questions for Dr. Vernon-Platt. The timing of this webinar was actually pretty perfect and was not pre-planned. If you tuned in last month, Mary Dunn and I did a lecture on survivorship and really talked about managing comorbid conditions, and cardiac is one of the main ones. So I think this helps stress the importance of, cardiac health and our roles as providers, how we help manage that, and also refer to our colleagues in cardiology to help.
Yes, definitely phone a friend when needed. And I know this was a lot of information in a short period of time. I do an EKG series that's about 6 hours long. So I was really trying to just pull in some really pertinent information for this hour-long webinar. But certainly if you want some more kind of information or insights on how to learn more about EKG interpretation, feel free to reach out to me. I'm happy to talk with you.
Yes, thank you. I know it wasn't easy to try to succinctly provide this pretty complex information, but I think it was really helpful, and giving those resources for us was great. So any questions before we let you all go for the evening? So somebody had also just commented that it was a great lecture. Thank you so much. Very informative. And commenting about an EKG site is ecgmaven.com. I'm not sure if that's something you're familiar with.
That's not one I've seen. But yeah, there's many out there. So find something that you're familiar with that's easy to access. There's some really good resources out there. And you have to put the time in to kind of go through, whether it's a Bravo series on YouTube or, one of those websites, and they will navigate you through all the different kind of EKG learning opportunities.
I have one final question as we wrap up with these final slides. We see a ton of electrolyte abnormalities in cancer care and are constantly doing electrolyte replacement. What's kind of a timeline for somebody to have hypokalemia that we would actually start seeing EKG changes? Is there?
Yeah, that's a good question. I don't know that there's a definitive timeline. I think a couple things. One, if it happens quickly, so if someone's potassium is always 4.7 and now all of a sudden it's 2.2, that's concerning because it's those acute changes, I think, that are more likely to lead to some type of an arrhythmia. I had a patient once, his potassium was always 6, which is high, but he had end-stage renal disease. He had had a prior liver transplant. He had some underlying cardiac dysfunction. He always had peak T waves on his EKG, and his potassium was always around 6, but that was his normal and had been that way for about 5 years. So I was less concerned about that. It had been someone else who'd never had a high potassium, and they showed up with potassium of 6 and peak T waves. I'd be sending that patient to the emergency room.
Great. So, of course, clinical context.
Always.
And I think most of the time in cancer care, we see that slow, downtrend and are able to intervene. So thank you all for your time and joining us this afternoon. Thank you to the University Cancer Research Fund, to the UNC Lineberger Comprehensive Cancer Center and the Lineberger Cancer Network, and to our amazing telehealth team who are behind the scenes making all the magic happen. Thank you to Tim, Benny, John, Oliver, Andrew, Patrick, and Barbara.